Kia ora koutou. Good morning, everybody. Welcome to the final day of the PHONZ conference. I'm delighted to have you all here. My name is Karina, and I'm one of the PHONZ steering committee members. It's my pleasure to chair the first session of today, but I'll first start us off with a karakia. Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mā kina kina ki uta, kia mā taratara ki tai, e hi ake ana te atakura, he tio, he huka, he hauhu, ti hei mauri ora. Right, well, we've got three very exciting presentations this morning, and it's my pleasure to introduce the first speaker, Dr. Erik Sturegård, who is the acting state epidemiologist and acting head of department at the Public Health Agency of Sweden in Stockholm. Erik will be presenting on communicable disease surveillance and control, a Swedish perspective. So I will hand over to you, Patrick. I understand this is a recorded presentation. But we can't hear the sound.
That again, my apologies. That should have worked. I love it when Zoom resets its controls in between meetings. On the top, sir.
Good morning, everyone from Sweden. I am joining you now in a pre-recorded session due to a quite substantial time difference. So this is actually recorded on Wednesday, but I'm very happy to join you on this quite brief presentation regarding communicable disease surveillance and control out of a Swedish perspective. My name is Erik Sturegård. I'm the acting state epidemiologist and acting head of department for Department of Communicable Disease Control and Preparedness at the Public Health Agency of Sweden. I'm a medical doctor and associate professor at Lund University with most of my research pertaining to tuberculosis and infectious disease epidemiology. And I'm going to give you a lecture or a presentation rather regarding how we have built our system for communicable disease surveillance and control in Sweden. And I will also mention a few lessons learned from the COVID pandemic. Well, I'll start out with a overview of our organization at the national level and at the agency level, as well as a brief presentation of our legislation to handle communicable diseases. Well, to start with, Sweden is a quite large country in geographical terms, but it's quite sparsely populated with only 10.5 million inhabitants. But it's divided in 21 regions or counties and 290 municipalities. And our regions and municipalities have a high level of self-governance, meaning that in this context, the responsibility for handling the communicable disease control is at the regional or county level. And if we look at the national level, where we have a public health agency where I work, and just to briefly present what we do, we are an expert authority with the responsibility for the public health issues at the national level that we obviously collaborate together with the regional and municipality level to organize. And our overall mission is to strengthen and develop the public health. And it was formed in 2014 and currently have approximately 600 employees with two offices, which with the one in Solna being the main one, which is actually a part of Stockholm, and one in Östersund, which is in the middle of Sweden. And if we look at our organization, we have 7 different departments under our director general, who reports directly to the government. And if we look more into the specific parts of the departments that are the most important in this context. We can look at the part of the organization working with surveillance and epidemic intelligence at the Public Health Agency of Sweden. And you can see that I've marked with red the units working with epidemiological surveillance, and with green arrows the units working with microbiological surveillance. And all in all, these units altogether work in collaboration with each other to serve the Swedish society and prepare Swedish society for a number of different types of health crises, obviously linked to communicable diseases. In order to support our work in surveying the communicable diseases, we have our Communicable Disease Act that regulates how various types of infectious diseases are reported to the government or to the agency. And overall, we can see that all communicable diseases are regulated in that aspect, that any individual in Sweden are obliged to take some measures to avoid spreading any type of infectious disease if it's avoidable, even though we do not have any legislation that makes it punishable by law to follow up. But then we have a number of diseases that are notifiable, meaning that a clinician or a laboratory finding the disease have to notify the authorities. And out of those, we have a number of diseases that are mandatory to contact trace. And out of those, we have a number of diseases classified as dangerous to the public health. And out of those, we have a very small amount of diseases that are classified as dangerous to society. And if we look at the most dangerous group, the smallest group, the ones that are dangerous to society, those include, for example, Ebola virus or smallpox virus. And for a time, we actually included COVID-19 or SARS-CoV-2 in that group. And if we look at our surveillance and programs, how is it managed, we can move into the specifics. For example, we have a national notification system for the notifiable diseases, if you remember from the last slide, called SMINET or SMINET, where the clinician can either, if a clinician finds a notifiable disease, he or she has to notify the county medical officers or the public health agency, or if the laboratory finds a notifiable disease, they too have to notify into this digital system. And this is a joint national database for the county medical officers and the Public Health Agency of Sweden, which is jointly owned and jointly managed between us and the 21 county medical officers. And the county medical officers have access to the regional data, and Public Health Agency have an overall access to all national data. And this is an important outbreak tool to coordinate outbreak investigations and to follow up any type of contact tracing, and is used to follow and organize the communicable disease surveillance work, but it's also used in specific outbreak investigations to follow up and find the final culprit if it's that type of outbreak. And if we look at SMINET during the COVID-19 pandemic, we used the notifying system by linking it to our other type of registries. For example, the National Board of Health and Welfare, where we got data from hospitalization, we got data from elderly care homes, and we got data from in-home assistance that could be linked to the testing for COVID-19. We linked it to our national vaccination registry, where we could see the vaccination status for COVID-19. We linked it to the Swedish intensive care registry, where we could get any type of ICU admission and link it to the notified COVID-19 cases. We linked it to our overall Statistics Sweden registries, where we have all the population with our geographical distribution, and we can actually calculate socioeconomical status for various groups, which could also be linked into the SMINET and the COVID-19 notification. And in addition to that, we could follow up our 30-day mortality by looking into the Swedish tax agency, which actually follows up everyone living in Sweden, including whether they are alive or not, and we could calculate in real time the classified COVID-19 mortality throughout the pandemic. And if we look into a more specific registry, the National Vaccination Registry, which is part of the Public Health Agency of Sweden's responsibility, it's a national registry that has been in use since 2013, where it's mandatory to report all vaccinations given that are part of the national vaccination program for children or are given within a national vaccination program for risk groups. And here was also included all vaccinations given against COVID-19. But for example, vaccinations given prior to travel, for example, are not included in the National Vaccination Registry. But into this registry, we have a lot of data, personal data, as well as data on the vaccine use, the data vaccination and batch numbers, etc., which means that the vaccination registry can both be used to follow up vaccine coverage and vaccine effect, but can also be used to follow up specific batches. If there ever was a specific problem linked to a specific batch, we can follow up who was given what vaccine. And this registry is linked to the Swedish tax agency, where we can see the individual's registered county and municipality of residence in addition to the date of birth. So we can get data on the geographical data as well as age groups and vaccine coverage. And for the National Vaccination Program for children, we can use the registry to follow up. And in this program, we have vaccination against 11 diseases, and it's offered at well baby clinics and through school healthcare in all of Sweden. And the coverage is generally high and relatively uniform throughout the country, where we have a bit lower, 85% coverage for Rota and HPV virus vaccines, but those are relatively newly adopted vaccines within the program. And if we look at the other vaccines used in the program, we have a 96% coverage, for example, against measles or rubella, among others. So overall, we have a very high vaccine coverage in our national vaccination program for children. And just to add, this is one of the more novel surveillance programs where you use wastewater surveillance, as I guess most countries do after the COVID-19 pandemic, and we're currently monitoring SARS-CoV-2, influenza and RSV virus. And we have a coverage of around 43% of the population analyzing wastewater from 18 wastewater plants. This is still quite new, and we use it quite a bit, but it's still in the, I would say, the technique is still in the early days to see the exact usage of wastewater surveillance and see the add-on effect of the surveillance compared to other type of surveillance systems. And if I move into the COVID-19 pandemic to look at how our system worked and what could be learned, we can move into the first part. For example, the Swedish strategy raised some amount of publicity in the world because we were viewed as moving into a more lenient approach compared to other countries. I would say that is partially true, even though it's not totally true. But the thing was that in Sweden we work very much with voluntary recommendations that are expected to be followed, but they are not they can be to some extent mandatory, but there is no punishable law where we can enforce them. But we could see that we had, from our more or less voluntary recommendations, we had a very good effect of our recommendations. If we look at the mobility in the Nordic countries throughout the pandemic, we can see this is by following mobile data, following mobile phones in the Nordic countries. We can see that in Sweden we did not reach the same effect on the mobility within Sweden compared to the other Nordic countries, but we could see that throughout the pandemic, in the later phases, we had the same type of recommendation, or the same type of effect on the recommendations, looking specifically at mobile phone data and mobility. But if we look at the vaccine coverage, I mentioned earlier that we had a very good vaccine coverage in our vaccination program for children. But we could see that with regards to the COVID-19 vaccine, we saw quite large differences between various demographic groups, mostly linked to whether you were born, Swedes that were born inside Sweden and Swedes that are born outside Sweden that have a history of migration. And I think this can be seen in a lot of follow-up data in many countries, that it was hard to reach certain groups within our society. And that is one of the things that we really have to look into for future planning. And if we look at the testing and the contact tracing, both the volumes and the costs, you can see the volumes in the graph to the left, and we can see that throughout the pandemic, it really in a way got out of hand in the Omicron phase, where we had very many cases and a large number of testing that overwhelmed our system, and we finally had to stop the testing and the contact tracing in that period, which was not that bad because the Omicron phase, with all our population already vaccinated, the disease was not that severe anymore. So that's moving towards the end of the pandemic. But if we look at the total costs, we can see that we spent close to 3,000 million euro for the testing and contact tracing between 2020 and 2022, which is a substantial cost that is difficult to show the true significance in effect on the pandemic throughout the years. And I think this is a similar problem throughout the world, that it's difficult to see to measure the effectiveness of the testing and tracing system. We can see that we approximately managed to contact trace individuals within 2 to 3 days, which may say that we had an effect on the overall spread of disease, even though the ones that were contact traced after 2 to 3 days, we probably were too late to actually make that significant a difference. And if we calculate the secondary attack rate throughout our system, we can see that within households we had an 18% secondary attack rate, which is probably an underestimation due to the fact that we did not test children to that large extent throughout the pandemic, meaning that we probably missed a number of cases. So I would say the secondary attack rate here is probably higher. And if we move into conclusions and lessons learned, we can say that, at least from the Swedish perspective, we still say that we avoid hard lockdowns if possible, and that we find school closures very questionable due to the fact that schools are very important for the future of our children, and the long-term effects of closing schools are substantial, and the gain is if not dubious, still is not very clear on how much you gain by closing schools, but you know that you have very negative effect on the health of children. We still focus in the future on the individual responsibility, making it a core fundamental principle, or still being a core fundamental principle in Swedish legislation, meaning that we always will move forward with voluntary recommendations, because we, at least in the Swedish society, we have very good effect on that, and we work a lot on informed understanding on the relevance of measures when we communicate with the public. We found that we had insufficient preparedness, both for stockpiles and system capacity. We have made an overview of our legislative and structural limitations, and we go through a number of projects where we look at the coordination between various stakeholders in society and how to manage the people that were most severely affected by the disease, especially in elderly cares, and how to reach hard to reach groups with our public communications. And we are well aware that the next pandemic will not be COVID-19, meaning that we see there are risks of excessive benchmarking using COVID-19. And for future preparedness, we see a need in Sweden to look at postponing cases. The cases that were most severely affected were affected or to a large extent in the first phase, because with the healthcare was not prepared and we did not have the medications needed to treat. We need a rapid and comprehensive access to data. We need to work on our integration of various digital systems for data management, and especially in Sweden with our decentralized system with the regional systems, this poses an extra challenge. We're looking at our legislation to enable flexibility in our public health measures, so we can tailor our recommendations to various parts of the phases of the pandemic, but also in various regions in Sweden. And we see a number of research needs into clinical diagnostics and vaccines, of course, but also looking at the effects of various public health and social measures, because that's part of a follow-up that needs to be worked on. And obviously we see the importance of future international collaboration, both to keep our trade open and keep the access to medical medicines and other material needed for healthcare, but also to keep the collaboration of knowledge between various countries, so we're well prepared together. And with that, I think my time is over, and I thank you all for listening to this brief presentation.
Thanks, Erik, and thanks, Patrick. That was fantastic talk. Great to have someone from Sweden. Well done. So our next speaker is Isabella Tortora Brayda. Welcome. Isabella is a Principal Information Analyst from Public Health Scotland's Climate Analyst team in Edinburgh. And she will be discussing modelling heat-attributable health impacts in Scotland. Handing over to you. Thanks, Bella.
Excellent. Thanks very much. Sorry, I was struggling to turn off my turn my microphone back on. Kia ora koutou. It's great to be here. Thank you so much for having me. I just want to start with the caveat that it is currently 10:25 p.m. in Scotland, which is where I'm based. So please do forgive me if I stumble my words a little bit. But I'm thrilled to be here. And today I'm going to be presenting the work that we've been doing in the Public Health Scotland's Climate Analyst team, of which I'm the Principal Analyst. In particular, talking about the health impacts of climate change, focusing on heat-related deaths. So I'm going to start us out by framing the issue. I don't seem to be able to change slides.
Maybe stop sharing and then share again. Do you think that might help?
Yeah, I'll try.
Sometimes you need to double-click the PowerPoint window to get it to recognize that you're using the PowerPoint that you're sharing.
I see. Oh, there we go.
Yeah.
Is that working now? Excellent.
Yeah,
good stuff.
Good.
Sorry about that. Fab. So yeah, I'm starting this off just with a couple of quotes that I think frame the problem very well. And I mean, unless you've been living under a rock, you're very much aware of the problem that climate change is becoming increasingly across the world. I mean, in Europe right now, we've got a serious heat wave going on, particularly in the UK. We've already had some red alerts, historic records being broken. So it's very much a record, very much a problem here and now. And so this is a quote from the Belém Health Action Plan, and that came out of the COP30 in Belém. And I think it sums it up very nicely and concisely. Climate change is one of the most urgent global health challenges of the 21st century. And within the climate analyst team, data is our bread and butter. So I just wanted to include this one, which comes from the Lancet Countdown on Health and Climate Change, which is that climate data is crucial to effectively anticipating and responding to climate-related health risks. So that's very much the niche in which we are placing ourselves. So with regards to the rest of the presentation, I'll start off by taking you through the Scottish context. I'll chat to you about the modelling that we've done for our heat-related deaths publication. I'll take you through the results and then show you the ScotPHO indicators that we've produced. So ScotPHO being Scotland's Public Health Observatory, the Scottish equivalent of PHONZ. And then I'll wrap up with the implications of the work and the next steps for us in the team. So this is over the last 150 years, the temperature change that we've seen in Scotland since 1884. It's sourced from Adaptation Scotland, but in short, we are seeing that the climate is changing, temperatures are getting warmer, and we're seeing more and more hot years as time goes on, and the darker red bands indicate the hot years. So that's the brief history of Scotland's temperature, and we're looking forward into the future that projections we're going to be seeing warmer summers and drier summers on average. Generally speaking, the temperatures will be increasing across all seasons, and we're anticipating that on the whole the weather is just going to become a lot more variable and more unpredictable. So it really is crucial for us to get an understanding of how health has been impacted by climate so far, so that we can get a feeling for what we need to be doing to mitigate and adapt to those climate changes in future. So with regards to the Scottish context, we're quite a small country. Landmass size, we're like half the size of New Zealand, and we've got 5.5 million people. And so we're working with a relatively small sample size. The other thing that's really important to understand when it comes to Scotland and health and data is that health is devolved, which means that health is governed independently by Scotland than it is from England and from Wales. So our data is very much separate from English and Welsh data. And the knock-on effects of this is that studies that are done UK-wide can't always include Scotland. And so there's a little bit of a limited climate health evidence base, or has been up until quite recently. So we've been highlighting that we really need Scotland to have its own suite of indicators for the impact of climate on health. And we started out with heat exposure. This is a quote from the recently released Well Adapted UK report, which was commissioned by the Climate Change Committee. And it's a recommendation of a goal that we should be aiming for, which is that by 2050, excess heat-related mortality should be no greater and ideally lower than today's annual average. So our work was to establish what today's average has been and what it has been over the last 20 years. And the work from here is for us to try and make sure that that does not exceed where it currently is. So it's arguably an ambitious goal, but it's definitely something to be aiming for. And then this is just a screenshot of the report that we've produced. I encourage you, if you're interested, to go and check it out. It's the heat impacts on health in Scotland, deaths 2005 to 2024. So methods. Firstly, what is a heat-related death? It's actually quite hard to attribute a death to temperature. And that is, generally speaking, that when someone dies, even if it is due to heat, it's very unlikely that heat has been recorded as a cause of death on the death record. So you can't simply go to the death record and see if you can find deaths that have heat on it, because that would be a severe underestimate of how many deaths there actually were from heat. And it's more likely that the deaths occur due to a worsening of pre-existing conditions. And so for us to be able to actually capture heat-related deaths, we've got to use some modelling. And we use the distributed lag nonlinear model for this, which is a tool that enables us to capture the impact of exposures. So in our instance, high temperatures on the outcome, which is deaths. But the real merit of the distributed lag nonlinear model is that we can capture lagged effects, and it's a nonlinear relationship. So the lag comes into play where if you have someone who has a respiratory illness as an underlying condition, on a hot day, that respiratory illness may be exacerbated to a point of serious ill health, but they may not actually die until the day after or even the day after that. So with our model, we're able to capture the deaths that happen over that lagged period, as well as those that would happen on the day of exposure. We source data from the National Records of Scotland, for which we look at all-cause mortality, and we link this data to Met Office data that we access through the EPHSS portal, the Environmental Population Health Surveillance System portal, and we link the deaths to the maximum temperature and the relative humidity for each day of our 20 years. So the data spans from 2005 to 2024. We look at only the summer months, that being the Scottish summer months, of course, so that's June to September. We've got a 2-day time lag, and we account for COVID by using the number of COVID deaths on a given day as a predictor. And then we have included relative humidity as a covariate in the model as well. And then we do all of the complex modeling. We have some scripts that we run, and it spits out a couple of key model outputs. The first of which is this relative risk chart. This is an illustrative one. I'll show the actual results shortly. But from this chart, we have a histogram of the daily maximum temperatures. And then we have this relative risk curve, which shows how the relative risk of death changes across those maximum temperatures. And we extract 2 key thresholds from this. First of which is the risk increase threshold, where the relative risk begins to increase significantly. And then we have the high risk threshold, which is the point where the relative risk of death is a 10% higher rate of risk of death than it is at our optimal temperatures, which is illustrated by that green section there. And then the next output that we get from our model is the deaths attributable to high temperatures. So we basically take that relative risk curve and we look at those key thresholds that we've identified, and through a little bit of extra coding, we extract the number of deaths that we can attribute to high temperatures over those thresholds. We then have also done a breakdown by different vulnerabilities. So we looked at age, deprivation, and sex. For age, we looked at the under 65s and the 65s and over. The Scottish Index of Multiple Deprivations takes into account income, employment, education, etc., and other social factors, and then of course male and female. And this allows us to identify differential impacts on different demographic groups, and from here we're able to then influence what appropriate adaptation and mitigation strategies should be for the different demographic groups, and we run the DLNM for each of those. And then finally, the last stage of our report is that we also publish the excess deaths. So this is using a method that the UK HSA also uses. We identify a heat episode, which is a day of 20 degrees or higher, 1 or more days of 20 degrees or higher. And then we compare that to the 14 days either side of that heat episode to identify how many excess deaths there are attributable to heat. Without further ado, we'll go on to the results. So you'll recognize this chart from before. This is the relative risk thresholds chart that I briefly demonstrated. So again, x-axis maximum temperature, relative risk on the y. The risk increase temperature in Scotland, where it starts to increase significantly, is at 20.7 degrees Celsius. And then the high risk threshold, where the risk is 10% higher than it is in these optimal temperatures, is at 25.8 degrees Celsius. So that's just slightly higher than our current heatwave day temperature. And then the second output is the attributable rate of deaths per 100,000. And this is over the 20.7 threshold and the 25.8 for the high risk. And in short, the attributable rate for both of those thresholds has been increasing since about 2007. 2006 was a heat wave year, which has a high number of associated attributable deaths. And 2024 was a particularly cold year. So they're somewhat anomalies in time series there. And then this is the vulnerable populations. We looked at the average attributable rate per 100,000 over the 20 years, and that was for over the 20.7 degrees Celsius threshold. And our key result from here stands out quite clearly is demographic on the x-axis. The 65 plus category has the highest average attributable rate of deaths per 100,000. So those are our most vulnerable risk population. And then finally, this is just to compare the results from our DLNM model to the excess deaths, and to highlight that we've got a comparable range for our estimated deaths for both of these methods and similar peaks, but we have broader confidence intervals from the associated, the excess deaths analyses. So that's all of the key things that are in the report. And then accompanying that, we've got our interactive indicators. We wanted something that was nicely accessible for our stakeholders to be able to explore things in different granularities, to look at different geographies and to really dig into their own regions. And so we use the existing platform of the ScotPho Profiles tool, where there are over 250 indicators. So if you haven't come across it, do go check it out. But we've created our own climate profile that we've added to it. And the heat health indicators we've included are the modelled rate of deaths attributable to heat over the risk increase threshold. Then we've got the modelled number of deaths over that threshold. And we've also included 3 weather indicators. So we've got the summer mean of highest daily temperature. Then we have the summer maximum of the highest daily temperature. And then finally, we also have the number of days at or above 25 degrees Celsius. So these are the ones that we've added, but as part of that climate profile, we've also included an existing indicator from elsewhere on the ScotPho tool, which is the population aged 65 plus. So where we've identified them as a particularly vulnerable group, we wanted that to be accessible to our stakeholders so that they could see where, which regions in Scotland had the highest population for the over 65s. And this is just a quick example of what it looks like on ScotPho. I encourage you to go and check out the ScotPho profile for yourself and have a click around and explore it. But we've got all of the different regions here. This is health board level for the modelled deaths rate, modelled number of deaths. And then it comes with an accompanying bar chart along the side, so you can compare and contrast the modelled number by health board. And then we also have a time series of that attributable deaths over that threshold too. So implications from our work. We've been able to improve the understanding of heat health impacts in Scotland. And in doing so, we're also able to support the development of Scotland's adverse weather and health plan and identify which thresholds should be considered for that plan. We're supporting the development of monitoring surveillance system. And through all of this, we will be supporting the resilience and adaptation planning for climate adaptation within Scotland. And we've got active links with various stakeholders who are involved in that. But this is just the beginning. We are a relatively new team, and we've got some exciting upcoming work. The next one, hopefully on the horizon, I don't want to say a publication date yet, but it's heat-related hospitalizations. This is exciting in particular because we have a much larger sample size when we're looking at hospitalizations than we do deaths, which means that we're able to do a broader range of demographic breakdowns. And so we will be including analyses by different health condition type, as well as a few more different age breakdowns. And then we'll have sex and deprivation as well. So keep an eye out for that one. As I said, I don't have a date, unfortunately. And then another piece of exciting work that's going on by the geospatial team within Public Health Scotland is some flood vulnerability mapping. So the geospatial team has been taking the flood risk maps from the Scottish Environmental Protection Agency, SEPA, and has started linking that to different demographic vulnerabilities so that you can highlight where the different vulnerable groups are and whether they are also in high flood risk. So that will be really, really useful for those who are needing to make decisions about putting in flood defences and the like. And so with all of this work that's going on across PHS, we're starting to paint a much clearer picture of climate vulnerability across Scotland. So thank you very much. Keen to take any questions. I think we might be doing that a little bit later on. Am I right? But yeah, thank you very much.
Thank you so much, Bella. That was awesome. Patrick, are we doing? Do we have time for questions now, or shall we?
We do have 5 minutes free for questions. If there are any, you can kind of put them to the Q&A menu or the chat, or if you'd like to ask them in person out loud, use the raise hand button and I can unmute your microphones.
Barry.
Thanks, Karina. Bella, excellent. Well done. Highly impressive presentation of the work that you do. What interests me is that Public Health Scotland has actually taken this under their wing and are doing it. And I think that, how did that come about? I mean, not many agencies actually do that. They farm them out or get somebody else to do it. But you've actually, Public Health Scotland's adopted this work, and I think that's highly impressive.
Yeah, no, it's really great. I think Public Health Scotland is keen to kind of encourage innovation and ideas that people have within the organisation. So I think this work, I mean, it was the climate analyst team came about a few years ago on the back of I identified that we didn't actually have any climate indicators in Scotland, and was keen to kind of do that out of my own interest. Climate change is something that I've always wanted to do something about. And so when I suggested that I was interested in it, they were very supportive of me getting underway with that. And then ultimately acquiring more funding to be able to expand the team and then to prioritize this work. So it's been quite a gradual process. But I think it's undeniable that climate change is one of the biggest crises that we're facing. And it's something that we should be doing our utmost to ensure that the right data is available. And Public Health Scotland has been cognizant of that and supportive of our work to make sure that we're doing our bit and leading the way where we can. So I've been fortunate to have that infrastructure.
Right.
Thanks, Bella. We have a question from Sarah. Thanks for your question, Sarah. Will you be looking specifically at risks in children?
Yeah, great question. Thanks, Sarah. We would have liked to have done it for our deaths analyses, but it's quite a small sample size that we're dealing with when it comes to child mortality. And so we weren't able to produce robust models for that particular breakdown. However, with hospitalizations, yes, we will be looking at hospitalizations in younger age groups. We're still finalizing exactly which age groups we'll be looking at, but there will be health risks in children within that publication. So yeah, look forward to that coming out.
Awesome, thank you. Chris.
That was an excellent talk, Bella. Thank you very much. I did a little bit of work, nowhere near the scale that you're working at, down in Dorset, and I had some interesting results, as you'd probably expect. Although cold deaths will decrease in Dorset and heat-related stress deaths will increase, we're still going to have a lot more cold deaths in Dorset. And the bigger surprise was that this really confounded any really good narrative or storytelling on my part. People didn't want to know about that. They already weren't dealing with cold stress related mortality. Have you come up with any new ideas on how we tell this story and how we get people interested?
Yeah, I mean, that's a really great question, and it's totally valid for Scotland right now as well. We don't have the same level of heat that's going on in England even, and cold is definitely one of the biggest issues. But I think what we're trying to raise awareness of is that there might not be that many heat-related deaths now, but there will be more as time goes forward. And right now what we're doing is we're charting that baseline so that we have that metric to the benchmark from which that we can gauge what the future would look like. But also what we can do with this is hopefully stay the progression of heat-related deaths. If we put adaptation and mitigation in place now, we hope that we don't actually see that death rate increase in the future. We want to keep it where it is right now. And I think this is all about prevention as well, is that these are preventable deaths in a lot of instances, not in all, but if we can do something to prevent these deaths, even if there's fewer than we would have in the winter months, there's still deaths that we should be doing all in our power to prevent. So I think that's probably the narrative that we're taking at the moment.
It certainly does seem that a lot of people in England are surprised by the number of extreme heat days they've had over the last 2 years. I mean, I'm not, but they are. And I wonder maybe we can use that surprise, that element of surprise that people are finding that this is happening and much faster than they ever imagined it would happen. If we could use that in our storytelling. Be interested to see what you guys do in the future. I'll keep an eye on you now that I know that you guys exist.
Thanks very much, Chris.
Thanks, Chris, and thanks so much, Bella. You have done a fantastic job, and I realise it's so late in the day for you, so really appreciate your time and look forward to the report coming out. Thank you.
Thank you very much.
So we've heard from Sweden, we've heard from Scotland, and now we're heading to Ireland. So I'd like to welcome our next speaker, Dr. Abraham George. Welcome. Abraham is the Director of National Health Intelligence, HSE National Health Intelligence Unit in Dublin. And he will be talking about leadership in public health intelligence, my journey so far and key reflections. Over to you, Abraham.
Thanks. Can you hear me?
Loud and clear.
Excellent. If I can just share my slides in slide mode. Can you see that?
We can.
Excellent. So thanks for inviting me. I'll try and be as succinct as possible. I have a few slides to cover. So I'm just going to talk a little bit about my journey as a public health consultant back in the UK, where I was working there for 15 years before I moved into my current role as Director of National Health Intelligence in Ireland in the HSE or Health Service Executive. What I thought was I'll start with just talking about a few key principles around how it's shaped my thinking around in terms of public health intelligence practice. And then just a brief example of the work that I did back in the UK and how that's sort of shaping my ideas around the sorts of advanced analytics here with my team and with the wider public health department in Ireland. So I'm not sure how many of you have seen or are aware of the Gartner Analytical Continuum. I came across it about 12 years ago, and it was actually quite an eye-opener for me. By that time, I'd already been working as a consultant for a number of years, and given my past role working as a public health consultant in the UK in a local authority public health department, much of the intelligence work I was doing was mainly around sort of ethnological kind of surveillance kind of analysis. And actually, but what I was becoming more sort of faced with were questions, more complex questions coming from, particularly from commissioners in the UK. As you know, there's a commissioner commissioner provider kind of arrangement in the UK in terms of purchasing and delivering health services. And actually they were asking much more complex questions around, not around just looking at trend analysis around health inequalities in the past, but actually analysis or how will services or how will the population change in the future if we were to invest more in prevention. So the Gartner Analytic Continuum I thought was an interesting sort of perspective around what sort of analytics we should be investing in based on what kind of questions we're trying to answer. And it's more on not a lot on what happened in the past or looking at causative analysis, which is why things have happened, but more of predictive analytics and prescriptive analytics, which is particularly around what's going to happen in the future. And so the types of analytics that we're thinking of doing actually becomes more of not just the usual kind of sort of population segmentation, risk strat, or evaluation, but actually also simulation modeling. So that sort of gave my sort of perspective around how analysis should be undertaken. But then taking a step back, actually, there's a different worldview that I was thinking around how data and analytics should be sort of undertaken. And I think that the concept of systems thinking also becomes particularly important, and that complexity science lens around how we look at the population. So I don't know how many of you are aware of systems thinking. I think I see Chris Kelly in the hi Chris. It's been a while since we've touched base and all that. So Chris knows pretty much what I'm talking about because he's been preaching this for a while anyway. So the point of systems thinking is about looking at the population as a complex system in terms of understanding those relationships, boundaries, and perspectives, and then using a specific set of tools and methods around how to actually understand and how to actually solve problems. So there is a difference between systems thinking as a mechanism, and that actually supports systems leadership, which I think is a sort of a different sort of discipline. And why is this important in public health? Well, I think what is happening now is increasingly public health problems are no longer a simple linear cause and effect. Actually, there are lots of critical interdependencies and risk factors that actually predispose or have an impact on or are related to a risk factor versus to the outcome as well. So obesity is the classic example of a complex system issue. And we are working in a multi-agency or a sort of multiple stakeholders in terms of tackling the solution. And so therefore it becomes almost like a wicked issue when we're trying to actually tackle issues within public health. Um, and I think apart from obesity, I mean the other thing also is that, I mean, sorry, not obesity, but the other important thing is about conflicting perspectives around, what kind of interventions can actually have an impact on a particular public health issue, like for example in smoking. So I think that's an important thing that we need to take into mind, especially when we look at that in terms of what sort of data we should be capturing in order to actually solve problems. So, and in systems thinking, we have complex systems which actually are measured by three properties, which are called emergence, feedback, and adaptation. So essentially, it's all about the relationship of different factors within a complex system and how they interact with each other. So in feedback, for example, it's like a particular risk factor will either have a positive effect or a positive feedback effect or a negative or a balancing effect on an outcome. So it's those kind of things that we need to be bearing in mind into around complex systems. I don't want to go into too much detail around that because I think I've only got about sort of ten minutes left anyway. But I'm happy to touch base with people who want to know more about the importance of systems. Uh, a little bit about the work that we've been doing, that I was doing back in England before I moved to Ireland, which was around the emerging importance of linked data sets to actually undertake some of those advanced analytics, which obviously requires that kind of complex systems or systems thinking approach. So population segmentation, I would see as a particular perspective around, applying a complexity science approach of understanding the population, because we're no longer looking at things in terms of single chronic disease. We're looking at multimorbidity, frailty, the fact that the the high risk groups within the population that cost the most usually have multiple long-term conditions as well as other complex social care needs, and so they have a much more per capita consumption compared to the rest of the population. So segmentation, and so it's important that we have to have integrated data across different registries, different organizations in order to actually understand that multidimensional view of individuals aggregated to a population risk group. And then when we are starting to look at interventions, whether they work or not, again, there are specific statistical methods, particularly like natural experiment methods, where we need to be actually looking at, well, how is this risk group, how is the intervention actually impacting on a particular group, and whether there's any particular significant difference between sort of the rest of the population or a comparator group. So we've been doing we were using a linked data set across Kent, where we were doing these kind of advanced analytics, linked up data, primary care data across the whole of the population of Kent, around 1.6 million population, and we did that for a number of years, and it worked well, particularly for our health needs assessment work that we were doing there at that time. Fast forward now to last year when I moved to Ireland. So in Ireland, a population of just 5 million, where the public health department, which was largely very much focused on health protection, went through a major restructure and reorganization in the last few years, where they started to develop the other domains of public health practice, particularly around health service improvement, child health, and in particular health intelligence. So there was a major restructuring, reorganization of the different public health teams into sort of one sort of a distributed sort of team made up of 5 national teams and then about 6 regional public health teams. and health intelligence was a big figure, big in the whole sort of reorganization. And so, in terms of health intelligence provision, I was actually I'm representing the National Health Intelligence Unit, which is a national team, but working alongside the regional health intelligence team, which at most of the time it's actually only just a health intelligence consultant rather than a full-fledged analytical team. So there's a significant variation in capacity and capability around health intelligence across the public health department across Ireland. So there was there's a big demand for the kind of expertise that we are actually delivering. But there's a lot of exciting opportunities also within the public health reorganization. We've just generated a new strategy for which we are now working together to deliver action plans. And some of those action plans are health intelligence focused. And there are some critical enablers that could actually help us to do a lot of stuff. For example, we don't have a linked data set yet in Ireland, but the Health Information Act has just been passed. Actually, then sort of promotes the importance of unique patient identifiers to actually link up data. And then obviously that will pave the way for the new emerging electronic health record, which will probably get mobilized in the next sort of 2 to 3 years. So what I've been doing with our health intelligence team, our NHIU team, and working alongside with the regional teams is trying to promote the importance of advanced analytics, particularly around 4 areas. As I mentioned before, population segmentation is one area that I think is really something that we need to be doing, particularly to understand that complexity science approach, understanding particularly how these segments contract or how they change over time, how from the mostly healthy population moving into a state of people with long-term conditions, moving into risk groups having frailty and dementia, organ failure, things like that. And so that helps us to actually to understand the population in a more sophisticated way that actually helps in that sort of broader kind of program-based approach around population health management, which I'm presuming most of you might be aware of. So that's one area of work that we're trying to do, and there's some specific work. Although we don't have a linked data set, we're trying to start off that work just using the hospital data that's available across the hospitals in Ireland. So these kind of slides that I'm showing you are actually taken up from a particular consultancy based in the UK called Outcomes-Based Healthcare, and they've been doing a lot of work with NHS England around this. But there are different segmentation tools that are out there that actually help you to segment the population in a sophisticated way. The other big advanced analytics that we're trying to do is also risk stratification. So again, seeing whether if we can get the segmentation work done properly, then maybe we'll try and do some risk stratification work to see whether we can actually develop a machine learning based approach to develop risk stratification tools to identify people who are at risk of rehospitalization. Now, I think the jury is still out around whether these interventions in terms of actually deliver, to actually affect population health management, to actually deliver integrated care and actually reduce healthcare demand. I think the jury is still out in terms of the evaluation of that. And I think there's been multiple studies that have happened both in the UK as elsewhere. And I don't think we've actually got the sort of full burden of proof that it's actually working. But I think that these kind of tools are still something that we should be trying to do because it gives us more intelligence around what our population is, who are the high risk groups and how are they changing in real time. So there are multiple tools for risk stratification, like the Johns Hopkins ACG tool, which you can easily find in the internet. In fact, I've been involved in specific studies around developing machine learning risk stratification tools based on machine learning on specific chronic disease, like in lung cancer. So and that's been quite an eye opener for me because that gives me an understanding of how important a linked data set is essential in terms of actually applying these kind of advanced analytics. Um, and then I was talking about evaluation, and I think that's really important. I don't know if you've seen the government handbook of evaluation in the UK. It's called the Magenta book. If you Google it, you'll find it. And I think it very succinctly defines the three types of evaluation: process, impact, value for money. I would think that a lot of the evaluation that you do is around process, but it's not very authoritative in terms of measuring outcomes. Value for money is your sort of health economic evaluation, which actually would be the gold standard. But you would need that kind of subject matter expertise to actually do this in sort of at scale and within a frontline sort of public health setting. I would think that if you've got a linked data set, actually you should be focusing and investing more in terms of impact evaluation kind of methods, and particularly around the use of natural experiment methods where you're able to follow up a cohort or a population over time and basically control that evaluation, basically comparing to with a control group. So it's that kind of stuff that we would want to do. And then the thing that we are actually doing now, because you don't really need linked data sets to actually enable it, is the kind of simulation modeling approaches. So, and particularly where this is something that I was doing in my previous job or leading and work in that regard. And then now I'm trying to do the same thing now in my new team, which is system dynamics modeling. That being said, when I joined this my team in Ireland, they had already been doing a lot of modeling, but more on the discrete event simulation type, which is another type of simulation modeling. But system dynamics, from my experience, is actually lends itself well in public health practice because it's very much suited to actually scenario test particular broad health policies and seeing how it impacts on the wider population. And given that a lot of the work that we do in public health practice is actually trying to see how the prevention agenda impacts on the population. So again, there is a lot of work that I've done around this, and there are papers that I can share with you. At the end of the slide, I've got a list of publications that you can have a look at. I don't want to go into too much detail around that. So, but if you look underneath the bonnet, it resembles almost like an enormous wiring diagram in terms of the types, in terms of stocks and flows that you have to sort of conceptualize to understand the changes in health states of a population and how they change over time, and then applying those risk factors and assumptions. So key reflections. I would say that actually a lot of the intelligence that we've been doing for many years has been very much around surveillance, but I think we need to be moving towards advanced analytical approaches. And rather than just leaving it to academic colleagues, I think we should be doing it as a partnership with them. And actually, we need to bear in mind that actually it's not data just in the healthcare sector we need to be linking up, but actually data even outside the healthcare sector. And that's what we call cross-sectoral data linkage. But the linked data set mobilization, it'll take a lot of considerable time. So actually, there is a need to actually try and do this at scale and build that capacity and capability brick by brick. And over time, we can start to build up those use cases and influence the sort of senior leadership to invest more in that kind of analytical partnership approach. And then we work as a team together across different teams to do those different types of analytics. And where we can collaborate with the academy to publish. And these are all the publications that I've sort of done in the last sort of 4 or 5 years. They're all available on the Kent Public Health Observatory website. I'm hoping I can do something similar also in Ireland when probably within the next couple of years, but we shall see how that goes on. Hopefully that gives a whistle-stop tour of what I've done, and I'm happy to answer any questions.
Well done. Thank you so much, Abraham. That was fantastic. Just a question from Mazen. Morning, Mazen. Checking Barry and Patrick whether the presentations are going to be made available to everybody.
Yes. Yeah, I'm very, very happy to share my presentation. I'll send it to Barry if that's okay, and then he can circulate it.
Awesome, thank you.
But to answer the question, yes, we are recording them and we'll make them public
Okay.
sometime next week in theory, if we're organised getting them sorted out.
Thanks, Patrick. Chris.
Abraham, always wonderful to see you and to hear from you. You've
Likewise.
settled in, or just barely settled into North Ireland now. How is there, from the outside, they seem very traditional public health. How are they responding to this work, and particularly the systems thinking stuff?
They're looking at it. It's interesting because so I'm based in Ireland, actually in the Republic of Ireland rather than Northern Ireland. So this is in
right,
Dublin,
sorry.
actually. So they've got a different system in the sense it's called the Health Service Executive which is the equivalent of the NHS, but the public health profession, the public health sort of workforce are entirely based in the HSC rather than in local government as compared to the UK.
Okay.
So and they're all have a medical background, but I think what is interesting is that they've all just only recently moved away from a traditional focus on health protection, which was what public health practice was most about in Ireland, and
Right.
having to
Okay.
contend and deal with healthcare, public health, the health improvement, all of the other domains of public health practice. It's a steep learning curve. So, so they're having
Okay.
to they're having to sort of organize themselves to try and sort those, to start to make an impact on those other domains of public health practice. The systems thinking is interesting because they are, even though they're having to play catch up compared to what we have in what is happening in the UK, they are sort of they are sort of understanding the importance of that systems thinking approach because of the sort of broader discourse around the importance of systems leadership. Now, systems leadership, everybody talks about that and the need to lead across different teams and things like that. But I think what they were interested to hear is actually hear the messages around, well, what are the specific skill sets that are required to actually enable systems leadership? And that's so far the message I've been talking about around systems thinking and of which system dynamics is a key skill set within systems thinking, they seem to be quite positive. But then time will tell in terms of them embracing some of the complexity of those skill sets, if that makes sense.
Yeah. No, good luck. I look forward to hearing from you.
Thanks.
Thanks so much, Abraham. So that concludes our first session of the day.
So I'm using those insights to drive system level improvement. Thank you for the opportunity to be here today. Okay, today I'm going to talk about the New Zealand Atlas program, and my presentation will focus on few methodological details, what information we present, and I can talk through some recent examples that when we have used Atlas insights to drive quality improvement. Okay. So the New Zealand Atlas of Healthcare Variation was first introduced in 2012 to shine light on how healthcare varies across New Zealand. It highlights regional and demographic variation across various health conditions. The purpose isn't to judge or prescribe an ideal level of care. A high rate isn't automatically good. The average is not the benchmark. Instead, Atlas is designed to prompt debate, to help clinicians, planners, and ask the right questions, like why does this variation exist? What's driving it? What does it mean for equity? By highlighting these differences, the Atlas becomes a catalyst for quality improvement. It encourages teams to reflect on their own data, compare with their peers, and identify improvements to deliver more consistent, equitable, and effective care. And when the data signals a concern, we don't spuddle. We seek a review, not to blame, but to understand. We talk with the relevant people, look at the context behind the numbers, and work together to identify what can be done. So Atlas is organized by domains. Each domain represents a specific clinical area. And within each of those areas, we have developed indicators guided by our expert advisory groups. These indicators help us to measure performance, identify variation, and ultimately improve outcomes. So we currently have these these topics on our Atlas, but we are hoping to publish a new one very soon. So we have asthma, and we have indicators focusing on asthma admissions, dispensing of preventer and reliever medications. In the chronic obstructive pulmonary disease, we have prevalence indicators, admissions, and triple therapy dispensing indicators. And in the community use of antibiotics, we present antibiotic dispensing data by region. In the contraceptive use by women Atlas, we present prescribing rates by type and by demographics as well. And diabetes atlas, we present estimated prevalence, medication, monitoring, and complications by demographics and region. And in the gout atlas, we present estimated gout prevalence and medications like urate-lowering therapy and other medications as well, indicators as well. In the mental health and primary care atlas, we present results from the patient experience survey and also medication dispensing as well. In the opioids atlas, we present dispensing rates, duration, and type of opioids dispensed as well. In the polypharmacy, we have polypharmacy indicators among people aged 65 plus. And surgical procedures, we currently have just 2 indicators on the surgical procedure atlas, which is tonsillectomy and brome, but we are expecting to have more of new indicators coming soon. The methodological aspects that I mentioned. Firstly, we bring together national data collections. These include key data sets, including the national minimum data sets, which is our inpatient data, the pharmaceutical claims data collection, PHO enrollment collections, laboratory claims, and patient experience surveys, and others as well where relevant. Secondly, we work with the expert advisory group consisting of domain-specific clinicians, subject matter experts who help develop, validate, and agree on indicators, ensuring they are clinically meaningful and relevant for practice. Thirdly, we analyze data by age, gender, ethnicity, geography. That means health district, and sometimes in some cases by PHO and rurality. And finally, we move to visualization and publication aspect, where data is presented through interactive maps, simple graphs, and commentary on the website, supported by write-ups, actually, that help to interpret key findings in the context of the clinical guidelines, and linked to other relevant information that we might have. This slide explains on how we define our cohorts, which is actually a very crucial step for each atlas. So here are some examples. Starting with diabetes, we use the National Virtual Diabetes Register. This is a well-established method that combines multiple data sources, including laboratory test claims, pharmaceutical dispensing, hospitalization data, to more accurately identify people living with diabetes. For the gout, we use a health tracker definition, which identifies people based on combination of hospital admissions and dispensing of gout-specific medications. And for COPD, cohorts are identified through medication dispensing and the hospitalization data. We use clinically informed, data-driven definitions to ensure cohorts are accurate and meaningful as possible. Cohort identification probably will become more straightforward once we have national-level primary care data when that becomes available. So as I mentioned, I will quickly talk through results from one of our recently developed COPD domain. Then I will talk through how we have used these insights for quality improvement. So COPD, chronic obstructive pulmonary disease, is the 4th most common cause of death in Aotearoa New Zealand, and the 3rd most common cause of death in Maori population in New Zealand. So in 2023, we found that about 66,000 people aged 45 years or over were estimated to have COPD, an increase of about 20,000 from 2018. And in 2023, Maori had the highest estimated prevalence of COPD across all age groups. For example, among those aged 65 to 74 years, Maori had the highest prevalence at 11.8%, followed by Pacific peoples at 5.1%, European populations at 4.1%, and Asian population at 1.2%. Nearly half of those people identified with COPD have regularly received triple therapy. When I say regular, we define regular dispensing as medication dispensed for at least 3 quarters out of 4 quarters in a calendar year. In 2023, about 7,400 people were admitted to hospital with a primary diagnosis of COPD in New Zealand, and 40% of those did not receive triple therapy on a regular basis after their admission. And we also analyzed COPD indicators by rurality. And we found that COPD prevalence was lowest in the most urban areas across all age groups. And hospital admissions and influenza vaccination rates were lowest in most rural areas. So for more detailed results on our COPD topic, we encourage you to go to the website. But I will talk about how we have used these Atlas insights for the quality improvement in practice. So we have developed a clinical audit template in partnership with General Practice New Zealand and the New Zealand COPD Guidelines Group. The intent is to make the data clinically meaningful, immediately usable, and help practices move from insights to action. On the left, you can see some of the example of audit indicators, these that flag potential gaps or areas for review. For example, people prescribed LAMA medication, which is a COPD specific medication, for 2 or more times in a year without a recorded COPD diagnosis. And patients with COPD who did not have spirometry recorded, or those with COPD who with repeated courses of steroids or antibiotics. Each of these indicators is paired with a clear action on the right. So rather than just highlighting the issue, this template supports clinicians to confirm diagnosis, improve coding, recall patients for review, and optimize treatment, including considering triple therapy where appropriate. And this slide highlights how the Atlas translates into real-world quality improvement operating at multiple levels across the system. At the national level, we do public reporting, we align with national programs, and we provide links to trusted resources such as Healthy 5, quality standards, choosing widely to support best practice. At the regional level, the focus shifts to more targeted action, like PHOs can use the data for benchmarking and comparisons. And there's also an ability to do bespoke analytics and generate patient lists and support for quality improvement training as well. And at the practice and practice, consumer, and community level, Atlas can be used to supporting staff education, linking with patient experience survey results, and we also provide resources that are meaningful for consumers. And we have some examples. We have what we have done in the past. For example, at the national level, now Atlas indicators have been included in the government policy statement on health. And at a regional level, there has been targeted work in the opioid management and Vibriosis, which has contributed to the reduction in opioid prescribing. At a local level, there were some initiatives like behavioral insights trial to provide feedback on high antibiotic prescribing GPs, thus reducing antibiotic prescribing by them. So in the slide, it gets to the heart of the Atlas, why Atlas is so important. It helps to ask the right questions about the variation and care. Firstly, it helps us to identify whether variation actually exists, or more importantly, whether the variation is clinically justified or unwarranted. It prompts us to look at the outcomes across different population groups. Are people experiencing the same level of care regardless of their age, ethnicity, or where they live? It also then we can explore whether there are any system level or structural barriers contributing to these differences. And the key question is about the consistency over time. Are we delivering care in a stable, reliable way, or do patterns fluctuate? The Atlas also allows us to assess whether clinical guidelines and best practices are being followed, and whether there are any gaps between evidence and practice. Equity is a critical lens here. Do all patients have fair and equitable access to care, or are some groups missing out? And finally, Atlas also helps us to identify where the regional differences exist, creating an opportunities for shared learning where one region is performing and others can learn and adapt. So the key takeaway is that the variation is not just something to observe, it's something to understand, question, and act on to improve quality and equity across the system. Explore the Atlas at hgsc.gov.nz to investigate the variation and various health topics by demographics and region. Thank you, Namihi, for the opportunity, and all kudos to PHONZ team who have made possible for all of us to share our work. And I'm very, very grateful for the learning, and I hope you all have a wonderful weekend. I'm happy to take any questions people might have.
Thank you, Nivy. We have a question in the chat from Melissa. Kia ora, some of this information is really interesting. Just wondering why some of it is so old, from 2018 for asthma or 2019 for gout. Also, if it will be possible to have an Asian subgroup and disaggregate in the future as this population increases. Thanks.
Yes, asthma go back to 2023. We have recently updated it. We have 2023 results on asthma. And gout, we are about to publish gout update in coming few weeks. There was significant update to the definitions and all of that. We have that, yeah. And is it possible to have Asian subgroup? For some atlases, we do have Asian subgroup. For some atlases, we don't have, because it's just because of the sample size issues that we run into. Because we don't want to show ONT graphs when, yeah, Asian subgroup was selected, and also Asian populations were, the split by North Island and the population distribution split by North Island and South Island is also different, and yeah, that is why, yeah.
Thank you. I think that's fairly clear. Yes, I mean, if I recall correctly, there was a sort of period during the COVID and the immediate aftermath when we didn't update atlases just because everything went very strange, and we've really put in the last 2 or 3 years, Nivy, that you've been leading some updates. Are there any now that are still older than 2020?
Years away, I don't recall receiving them.
Richard, Barry speaking. It does raise the issue why our standard national data is so old. I mean, it's been old for a long time, and we don't seem to be making a lot of progress on this. And for planning purposes, particularly, I mean, your mortality data, infant data, how can people, particularly that are planning services and even developing policies,
work on such old data? Yes.
Yeah.
Indeed.
We do have one more question, which I won't allow to go and be missed, from my colleague here at NPHS, Amanda Hunt, who asks whether this data that can be analysed to the mesh block level.
We haven't thought about it to analyze data by mesh block level. If I'm understanding the question right, whether we can see this by mesh block level is the question, right? It depends on the topic actually, because sometimes we run into it depends on the topic. If it's diabetes or where we have got a larger cohort, it is possible. It is possible to do that by mesh block, but yeah. And I'm thinking about what sort of purpose, because I don't have straightforward answer to that, but yeah, we do have a split by PHO and health district, and yeah.
How much lower can you go? Yes. Presumably you would run into disclosive issues or just very small very small. There's a response from here from Emily Mountier, your colleague, in the chat. Our current data holdings mostly don't show mesh, but we're working on this. There will be similar issues with sample size. So I think that is a good point. Those confidence intervals are going to be absolutely crazy on some of these very small numbers. So yeah, thank you. And Barry, yes, absolutely agree. The issue of delayed data, and I think mortality is particularly a challenge. Where we are waiting for the last confirmations from coroners on some things get really quite ridiculously out of time. If that's okay, and that was the questions. Thank you, Patrick. Thank you, Barry. Thank you, Nivy, very much for that presentation. I'd like to then, if I can, invite Nicola and Gillian. I can see Nicola, who is going to be talking to us about Vibriosis in Aotearoa, New Zealand. So, Nicola and Gillian, great to have you with us. If you want to share your screens, over to you.
Thank you. I am trying to share it, but I'm sorry. I thought that this would be really easy to do. And I'm not familiar with Zoom, and I've hit share and got a lot of options, and now I'm looking at them going, where is my presentation gone? Because it was right there and not appearing in my options. So I'm going to attempt to go entire screen, and I'm hoping that from there I can just do a little workaround. And I wonder if you can now see my presentation.
Yes, we've got you.
Thank you. Apologies for that. It's a pleasure to be here today with Gillian. And yes, we are going to talk about this bacteria called Vibrio and the range of diseases it causes, Vibriosis. So this slide's just got a few things in it that I want you to keep in mind as we move forward through the presentation. So Vibrio are bacteria, and they're naturally present in our aquatic environments, in our coastal marine areas. So they're found in the water, free living. They're also found in sediments, in and on shellfish, plankton, and other aquatic invertebrates. The presence of fecal contamination, say from human wastewater, is not related to the presence of Vibrio. They might enjoy those conditions a bit more, but they don't need that to survive. And key is that they quite like warm conditions. So a benchmark of about 15 degrees is used to indicate conditions above which Vibrio will start to be more comfortable. And of around 160 species, there's about a dozen that turn up in human disease. And these called gastrointestinal illnesses, also soft tissue infections and air infections. And people become sick through eating food, seafood, containing these Vibrio, or through being exposed to them in the aquatic environment. And now I've got more technical problems and it won't let me change my slides. We'll do that way. Workarounds all over today. Now, one particular species, Vibrio cholerae, is the cause of cholera. Now, we know from our New Zealand data that we don't have these species, or these types, I should say, here in New Zealand. So it's caused by serotypes 01 or 0139, and those that produce the cholera toxin. Now, the cholera is a notifiable disease here, and we only get people infected with these 01, 0139 toxigenic species who have returned from travelling overseas. However, there are a range of other Vibrio that cause this bucket of Vibriosis disease, this range of diseases. And the four are listed here: Vibrio parahemolyticus, these non-01, non-0139 Vibrio cholerae, so that's the non-cholera cholerae, Vibrio vulnificus, and Vibrio alginolyticus. Now, the other notifiable disease here of relevance in New Zealand is acute gastroenteritis if it is caused by Vibrio parahemolyticus. So we can look at the notifiable disease data, and we see this quite significant bump in 2019. And that was related to the first outbreak that we had in New Zealand, which was linked to New Zealand-sourced shellfish. So it's not the first outbreak we've had, but the first time it's been linked to seafood harvested from New Zealand waters. And there's been a few outbreaks since then, and also more attention has been paid, and I think there's probably more cases being notified as a result of these outbreaks. But when we look overseas, some of the best data available on Vibriosis comes from the USA. They've been nationally notifying any kind of infection, foodborne or non-foodborne, wound infection, ear infection, gastrointestinal infection, from any kind of Vibrio species. And they've been doing this for a long time. And the reason I'm showing you this image here is it shows those top 4 that I was talking about in terms of those that turn up most often in human cases, but also the blue bars for each of these species show those cases that were likely infected through foodborne transmission, and the green non-foodborne transmission. So aquatic exposure and foodborne exposure are both important. So this really makes us ask the question, what is New Zealand's situation? Now, there's been a lot of talk in this conference about data fragmentation, and this is a really good example of how this is happening. So we tried to round up what data we could about Vibriosis, and I've talked about what we could get from our national surveillance. We also looked at the hospital discharge and mortality databases, and there are some clinical codes related to cholera, foodborne parahemolyticus infection, and Vibrio vulnificus infections. At PHF Science, we have an enteric reference laboratory, and they receive any isolates from in the country from humans where that isolate is Vibrio cholerae, because we need to know if it's the cholera causing types. So we have some good information about cholerae from this database. They also receive isolates of parahemolyticus, and sometimes they can receive isolates of other Vibrio species for different reasons. And finally, we had a clinical diagnostic laboratory participate in this study. And from there, we were able to see Vibrio positive results in any kind of sample. So this really created richness to the data set. So what did we find? Well, we did find that those top 4 are causing illnesses in New Zealand. And the little blue dot down the side is the bit we already know, that Vibrio parahemolyticus is causing acute gastroenteritis. So let's look at the other parts of the story. The enteric reference laboratory told us a lot of things, but one of the big stories from that data was these non-toxigenic Vibrio cholerae. So it shows that they are causing gastroenteritis, they are causing ear infections and wound infections, and possibly they're also leading to some hospitalizations. So we know that these particular ones in this graph hadn't traveled overseas. So when we look at the hospital discharge data, there's this bucket of illnesses that have been assigned to cholera unspecified. All we know is this means it's not an O1, so it's not a cholera causing type. We don't know anything further about that. But the other big story from the hospital discharges was around Vibrio vulnificus. Now, this is actually quite a cause of quite severe illness, particularly in people with liver disease or diabetes. So we know that it's causing gastroenteritis and wound infections, but for some people that's leading to really severe health outcomes. And finally, we looked to the diagnostic laboratory, and the big story from this one was the presence of Vibrio adenolyticus, mainly as a cause of ear infections, often in children, also as a cause of wound infections, and for some, the infection was clearly serious because it was being detected in blood samples. So as we look across all of those databases, we see Vibrio parahemolyticus is also causing wound and ear infections and leading to hospitalizations. So that's the story from the data. And I'd like to pass you to Gillian, who's going to tell you a story more from the front lines.
Hi, thanks everybody. I'm Gillian Anderson. I'm a health protection officer working in Wanganui Mid-Central area. We have 2 touch points really with the Vibrio species, and one of them is in recreational water. And all of our officers work in a space in environmental health. We're environmental scientists, and we work at the interface of the environment and health. So in recreational water work, we provide evidence-based health risks on the risks and benefits of recreational water. We take appropriate action to minimise those risks. We support local authorities and their activities, and we investigate cases of disease linked to recreational water. Next slide, please. So we know our oceans are warming. There's plenty of evidence of that now. And a couple of recent reports that NIWA have put out have given us some really good information on those increases in temperature. So without our average is in 0.76 to 1.3 degrees Celsius as an average increase. And this is 34% faster than the global average. So next slide, please. What these reports also show is that there are periods of time when we are in marine heat waves, which is at least 5 consecutive days with an increased water temperature. And you can see from that graph, that diagram there, that the Western North Island in 2022 was actually in heat wave conditions all year. Next slide, please. Now you can look for any of that sea surface temperature anytime you want to. If you go onto the Met Service website and click on the marine weather forecasts, maps and radars, and then click on the sea surface temperature tab, you're going to come up with a graph like this. And that's a real-time temperature recordings for our ocean. Next slide, please. So the interface we have with foodborne illness is a shared space with MPI. MPI regulate the food and they manage risks in food production and processing, whereas we look at the diseases. So when someone gets sick, we'll do the follow-up and then feed that information back to MPI, who will follow up with the food production areas. We collaborate a lot when it comes to the outbreak management. And it's a very good collaboration and it can be very fast and effective. There's one really good example of us receiving 2 Vibrio notifications on a Friday morning about mid-morning. Did the first one and it was likely to be linked to mussels. And in that area where the person was unwell, there was due to be a 3-day mussel festival starting later the same day. And the industry had decided that the new food trend was going to be eating raw mussels. So MPI got hold of their local food safety people. We got our second case done and confirmed with them that both were linked to commercially produced mussels and both people lived in the same area as this mussel festival was going to be. So they got their guys there and those food safety officers reassured us that they had made sure that there were going to be no raw mussels served and that all cook safe temperature recordings were going to be done and they were refreshed in the mind of the stallholders. So we didn't get another case, thank goodness, because that particular mussel festival, there are thousands of people attending. Next slide, please. So we know we have got Vibrios in our ocean, and I know you can't read that map. I know it's not really the point of the map. The map really is showing you the distribution of where we're picking these sorts of things up from. This is a 2-month period in one bathing recreational water season that we would look at in 1 year. And they're right from the bottom, halfway up the South Island and all about the North Island. And then you look at the different kaimoana from which the infection is likely to have come, and you can see it's pretty much everything. Next slide, please. Recreational water, that other space that we work in, is a place where we're more concerned about the skin infections that may be occurring, so Aotearoa or vulnificus. And the Vibrio vulnificus, as Nicola was saying, can lead to quite serious health outcomes if a person has liver disease or diabetes. Currently, there's no environmental monitoring for Vibrio because our recreational water monitoring is looking at indicators of fecal pollution, and that's enterococci. In a couple of years ago, we had some rec water results that were really rather unusual because there were high levels of enterococci, but no sewage overflows and no rainfall. But what they did all have in common was there were unusually high sea surface temperatures at the time that they were sampled. So if we're going to look further at public health risk and contact recreation, we need to look at some parameters that we can potentially put in place for modelling. The key one is salinity and sea surface temperature, but the main one that will be indicative is going to be the sea surface temperature. Well, Nivicus really kind of likes the slightly higher temperature of about 18 degrees Celsius. Some of the other international models, they use chlorophyll A and sea surface currents. When we started talking about this with our regional council this year, they were explaining to us that not only do they take the microbial levels in all of these marine samples, they also take the temperature of the water at time of sampling, the currents, if any, and also weather conditions. We're not so worried about that. So some of that information that we need is being recorded, but it's not available to us currently. So can I have the next slide, please? So this presents us with some challenges going forward. We know our oceans are warming, and we know that our marine environment is changing. We also know, because of the evidence we've been gathering, that there are evolving public health risks associated with naturally occurring bacteria in our marine environments, giving us public health risks. So our current systems don't indicate the presence of Vibrio. We don't actually know what's happening, and we're relating it always back to what's happening with the food industry and what's happening there. But what about contact recreation? So what we need in public health is some relevant and timely data. Water temperature is an absolute key piece of information that we need, and it would be enormously helpful if all Vibrio species were notifiable. And then when we do disease follow-ups, we can start working out where these infections are happening and relating it to the surface temperature, and start to be able to put together a picture of what the public health risk is like. And we're just simply unable to do that at the moment. The last thing is that when you start looking into this area and you look at the research on the marine warming and other environments, there is no health voice. There is nothing mentioned about health. But I think Nicola and I have showed you today that there is very definitely a relationship there. There should absolutely be a public health voice in any of these marine climate change spaces. So there I'll leave you those three main challenges things we need to do going forward in this marine recreational water space.
Wonderful. Gillian and Nicola, thank you so much. That was a really fascinating topic of the interplay, I guess, of climate change and public health. So that was a great articulation of it. So thank you for that. Do we have any questions for Nicola or Gillian?
We do have one from Bryn, who has the hand up. So you are now free to talk, Bryn.
Hello, Bryn.
Or perhaps you would like to ask your question in writing, Bryn.
Working now?
Ah, there we go.
Yeah, apologies. Hello. Congratulations, Nicola and Gillian, on your publication this week in the New Zealand Medical Journal. Just a simple question. I work in the Northern Region Public Health Unit. Any recommendations you'd have for the units in terms of our data entry? As an example, if we have a non-010139 cholera and becomes not a case, it sort of becomes, we don't really record the other Vibrio cholera results. They become not a case, rather than convert them over to a gastroenteritis. But any tips you'd have for the public health units, please?
Look, for us, the pieces of information that are of most value is information on exposure. So how did that person get exposed? Did they they fall over the rocks at the sea, or cut themselves with a fishing knife, or did they have a wound and went walking in the sea? Or, you know, is it a gastro-type illness? So did they eat some seafood, and what seafood might that have been? Was it raw? Was it cooked? You know, it's that it's the hardest information to get, but it's like gold. So we have had a lot of discussions about, you know, what it would look like for all Vibrio to be notified. You know, it's a really ambitious goal, and we're not really sure if it's something that will happen in this country. But there are perhaps some steps we could take. And in terms of that non-toxigenic cholera, you're right. You know, as soon as the laboratory says this is a Vibrio cholerae, there's kind of the beginnings of that case information already being captured. And then that isolate goes off to the lab, and they say, oh, it's not a cholera causing type. And then it all stops, and you kind of feel like, wow, if I could take that bit just a little bit further, that will be one tiny step into improving the data that's available. I hope that answers your question.
Absolutely. We'll need to think some more as to how best to capture it, because there are ways, but thanks so much.
Thank you, Bryn. Thank you for your question. Amanda, I can see you got your hand raised.
You can unmute yourself now.
Okay. Yes. Can you hear me this time?
Yes.
Kia ora, kia ora kōrua, great presentation. Just wondering, Gillian, you said that, I noticed that you said chlorophyll A measurements could be useful. I just wondered, is that because do nutrients contribute to the growth of the Vibrios, or is it because they can indicate that there's stratification and delayed mixing, which would contribute to favourable environmental conditions for their growth and replication?
It's an interesting measurement because in some respects it's a breakdown of those chlorophyll, the algae population that then stimulates some of the Vibrio species to grow. We certainly know we can get that. Well, NIWA have shown us that they can get that, and they look via satellite to get that sort of information, and they use that as a surrogate for looking at what the temperature of the oceans are. Nicola, have you got anything more?
Yeah, I could probably add a little bit to that. So for us, the whole idea of associations between plankton and Vibrio is a really interesting research topic on its own. And we would love to have money to get a student to actually really look at this in depth. So in some models overseas, the inclusion of chlorophyll is significant sometimes and can add to prediction, improve prediction, sometimes not. It's really variable. But the biology that sits underneath that is that Vibrio actually quite like attaching to chitinous things. So they quite like attaching to zooplankton, for example. And so if you've got a bloom in phytoplankton, you've got a bloom of zooplankton feeding on that. So there's this sort of ecological and biological interactions that are sitting underneath it as well. It's unfortunate this is not an easy place to work. I think we should have chosen something easier, Gillian, because it's quite complicated and we're dealing with natural, messy systems. But that's the reason that chlorophyll A can be a useful indicator.
Thank you.
Thank you, Amanda. Well, Nicola and Gillian, thank you both very much for that excellent presentation. Really fascinating stuff. I learned a lot from it, so appreciate that. I would like to possibly hand over to our next speaker, Jacob Madden, who I can see just coming online. He's the Assistant Director General of Data Evidence and Analytics at the Australian Centre for Disease Control in Canberra. And he's going to talk about the progress on a federated data sharing model in public health for Australia. So over to you, Jacob.
Good morning, Richard. Thank you very much. Just confirming you can hear and see me all on stage. Perfect. Thank you. Well, kia ora, New Zealand colleagues. I am joining you from Canberra, over the ditch here in Australia. I would like to acknowledge the traditional owners and custodians of this land here in Canberra. It's the Ngunnawal people. I pay my respects to elders past and present. and want to extend that acknowledgement and respect to the First Nations peoples and traditional owners of the lands where everyone joining this call may be dialing in from, whether that's all across New Zealand and Australia as well. So, as Richard said, I am the Chief Data and Analytics Officer at the Australian Centre for Disease Control. Today, I just have a few slides that I wanted to walk through to provide a bit of an update on the work that we're doing to establish our data strategy. And a key component of that is work in improving data sharing in our federated model. Something which I know New Zealand doesn't quite have all the same challenges we have with states and territories, but many lessons to learn nonetheless. And the work in particular around standards and interoperability really providing the foundations for global collaboration as well. So I'm just going to see if I can share the slides that I have open. We will. I might. I'm not so used to using Zoom, so I'm more used to Teams these days. So someone just walk me through. I assume it's just, there we go, share at the bottom, and then that should.
That's looking good. Brilliant.
Yeah, perfect. Cool. So just to start with, recapture kind of what the Australian CDC is looking to achieve. So working to deliver broad data reforms to support national public health resilience. Just to kind of cast minds back, obviously, New Zealand, I know, going through a similar process at the moment with your COVID-19 response inquiry and responding to that. Australia had a similar process. One of the key recommendations, but also prior to that, it was a commitment of the government to create the Australian CDC. Public health resilience, I think, really is at the core of that. So my work is focused on data and analytics, but data and analytics as the kind of crux of some of the improvements we need in our public health resilience and sustainability more broadly. So our future state we want is a national data capability that strengthens our ability to anticipate and respond. So it's about earlier and with greater precision. So common experiences moving from data held across sectors and levels of governments to a connected ecosystem, moving from reactive with limited timely data to anticipatory decision-making, earlier signals, from data that's not always there when you need it to something which is more timely and decision-ready. Thinking again beyond program or sector boundaries. So what's moving towards health, environmental, social, and behavioral, all integrated effectively, and moving from specific population analysis, from general population analysis to more targeted place-based or cohort-specific insights. And so all of these things sound very common sense. And as I'm sure you can all appreciate, much harder to do in practice. So what we have pulled together, this is a draft of our, on a page, the Australian CDC data strategy. So the vision very clearly is to optimize the use and value of data for action. But really it's about delivering better public health outcomes. And so thinking about, I think the key words there really to focus on are optimize and value. I talk about it with my team as we want the data to be valuable, i.e. it needs to be relevant, it needs to be what people need, it needs to be there when we need it, but it also needs to be valued. And so that goes to the use, data without action. Data that isn't used is useless. And so thinking about how do we make sure that people value the systems and trust and value the data that we have as well. So the mission to connect, to deliver connected, timely and robust national public health data ecosystem that supports independent, expert and transparent advice. So that last part there is the core of the Australian CDC's role, independent, expert and transparent advice. And so our mission really is to make sure that, as I said, we have the information that we need when we need it and as complete and holistic as possible. So 4 strategic pillars. Today I'm mostly going to focus on the second and the fourth here, but going across stewarding national public health data, which is about our role as stewards in the system, working across states and territories, and the broader public health ecosystem. So with researchers, with public health units, with advocacy bodies, consumer groups, etc. So making sure that the data is useful across that system. So this is where authorizations and data governance come into play, but also data brokerage functions. So working collaboratively to get access to the data we need when we need it. So great example in recent health events, working with our Department of Home Affairs colleagues on how we can get migration data more efficiently into the system, things like that to better understand the profile of people, movement of people across borders, etc. Another great example when it comes to adopting a One Health approach across our organisation, understanding that public health data isn't always health data, but agricultural or environmental data is particularly relevant in understanding climate risk, understanding, for example, bird migration patterns, timely one at the moment. The second one there, modern technical solutions. This is about making sure we have the tools that we need to deliver the coherent, complete and high quality data. That points to a number of things which I'll walk through in a bit more detail around standards and interoperability in particular, and system solutions which allow us to capture and derive meaning from all of the disparate systems and intelligence points across the system. All of those two things are really important. So you kind of have the first two, which are about the kind of foundations and the data itself. And then that third one and the fourth one, the third one being, well, so what? Translating data into public health action. Having the analytical capabilities, we're exploring what an increased capability in forecasting and modelling could look like within the organisation, and starting to build an analytical priority pipeline. This is very much linked to that first pillar there around the whole public health ecosystem. So what capabilities do we have in-house to be able to do work that benefits others? How do we set our priorities most effectively? And how do we shift from descriptive analysis to predictive and prescriptive? What should we do? What could we do? Why do we need to do it, etc. But all of this really hinges on the fourth pillar there, which is building public trust. Something which I've had a number of conversations with global colleagues, including with New Zealand counterparts, fall into this pillar here. So a transparent data culture with genuine impact in partnership. So that includes working with First Nations communities, understanding the governance of Indigenous data, which includes not just how we report or how we talk about Indigenous data, but also what we collect, and thinking more holistically about the appropriate kind of health indicators. It also includes a broader piece on social license and trust in our data practices, which if you don't have that, the other pillars kind of fall apart as well. This strategy is underpinned by those 4 principles there: transparency, collaboration, innovation, and equity. Equity, really important. Having data which allows us to see inequity, and identify opportunities to improve equity. I think this is part of, it's the gateway to a broader program of work across the organisation on improving health equity and reducing disparate outcomes across community groups. Here, I just want to, as I said, focus on that second pillar about modern technical solutions. So sometimes the barriers to public health data sharing are related to governance. Sometimes they're related to cultural challenges, but often it's related to inconsistent standards and limited interoperability. So that leads to variable data quality and the inability to see kind of like for like across systems and sectors. I think being able to speak the same language is a particular challenge when it comes to looking across a systems view. And so our program of work here on modern technical solutions really is multi-pronged and focused on all of those different enablers. So data development and quality. This is, we're focused on making sure we have complete, timely and accurate insights. So the quality and usability of our data, closing gaps in how things are collected in one state, maybe different in another state, making sure we have that consistency in the national evidence base, but also incorporating new and emerging data sources in a way where it is standardized and consistent and able to be reproducible and sustainable in our systems. The second element there around data integration. I know this is something New Zealand does quite well with your statistics agency and your linked data sets. Similarly, in Australia, we have the person-level integrated data asset managed by the Bureau of Statistics, and we have what's called the National Health Data Hub managed by the Institute of Health and Welfare. Both of those data sets are excellent linked data sets across sectors and levels of government, but neither of them have notifiable diseases or notifiable conditions included in those data sets. So one of our major projects is getting agreement from states and territories to include that data set in those broader linked data assets. This will do a couple of things. One, it will improve access for researchers and research to understanding those insights. But two, more importantly for us, it creates that linkage and ability to see population trends, better understand social and demographic factors, better understand health service utilization, for example, vaccinations, hospitalization, use of prescriptions, etc. That's some really, tangible examples of how that can be used in practice that we've been discussing are things like being able to see whether someone who presented in hospital with an acute respiratory infection, whether that same person may have been in hospital 3 or 6 months prior and there was a missed opportunity for a vaccination encounter. So, some of those things, and then being able to double down on that and see, okay, well, is that happening in a particular geographic area? Is that happening in a particularly cultural or linguistically diverse community? Some of those factors which we may be able to see more clearly with access to integrated data. So there's a range of technical specifications underpinning that. So having a improved linkage spine, having the pre-authorization in place with states and territories and other data custodians, and having it in a federated model where we don't have to transfer all of the identifiers across on a regular basis, but we can work to ensure content data and identifiers are held separately but able to be linked effectively. Standards and interoperability, I think, is, as I said at the top, an area where we're thinking through how our work can support not just nationally coherent and timely insights, but how this work creates opportunities for regional data sharing and global solutions. So what we mean by interoperability really is the ability for information to be exchanged, understood, and used effectively across different organizations. And so semantic interoperability, do the words mean the same thing? Does the language hold the same meaning, etc.? But then standards support that interoperability by providing those definitions, the structures, the terminologies, and the rules, which allow those systems to work together without having to be identical. And I think this is the key here. Data allowing data to move between systems and the meaning move with it. And in a federated system, we can't assume that everyone is going to adopt the same systems or the same technology. So we need to make sure that we're focused on shared standards, governance, and arrangements which support that without needing to make everything identical. So as I said, this is underpinned by two kind of components: our broader National Public Health Data Network, which is bringing together all of the authorizations, governance, and processes. And then within that, the National Public Health Surveillance System, which we are currently scoping and designing, which is designed to strengthen timely surveillance capture and connect those systems rather than replace them. So that National Public Health Surveillance System, looking at, again, the fourth box there, innovative digital solutions. So how is it scalable, resilient, and AI ready? So the design, looking at an ontology and knowledge graph model, which will allow us to scale effectively during major public health events, but also have that standards-based data exchange across systems. I touched on this before, the fourth pillar. For me, this is really important that we don't get trapped in everything else I've said and all of the technical work, but that we continue to remember that this is hard and that it requires relationships and trust. So for us, reciprocity, making sure that we're acting truly as a national institution and putting the kind of public in public health as well. So thinking about what that looks like in practice for us is not just technical capability, legal authority, etc., but it's understanding co-governance, social license, and cultural safety. So co-governance, recognizing that data custodianship rests in a number of different places. And so how do we ensure that the decision rights are in the right place, but that there is still that acceptance for speed and efficiency? So some of the pre-authorization for linkage, for example, coming into play here. Social license, is really about being able to explain what we are doing, what we're doing, how we're using, how we're protecting people's data, and that we are always clear ourselves on what the public benefit of access and use looks like. And then cultural safety looks like active conversations and building those relationships in a way where we can talk about data with Indigenous communities in particular that respect their rights and the path to self-determination and reconciliation, as well as continuing to have the public health benefit where it is most needed in some instances. So supporting that clear public benefit and equity outcomes there. I'm going to stop sharing because I'm probably coming close to time, and want to leave a few minutes for any questions anyone may have.
Thank you, Jacob. I'm really glad that you sort of brought us back to these very complex issues of co-governance, of social license, etc. I'm very struck the contrast with the interesting debates in the NHS at the moment about their federated data platform and a sort of general outrage about who it's being given to, etc., and what this implies, which I think is quite interesting. So I would be quite interested, I'm sure there'll be other questions, about how you integrate the technical with the governance or whatever language you want to, or trust or social license issues here, how you integrate and make those trade-offs in your own mind in doing this.
Yeah, so I mean, just briefly, I don't come from a data science background. I come from a kind of policy strategy background. So for me, my driving force is always like, to what end, for what purpose? And so the technical needs to always serve an outcome, and that outcome is always for the community. Sometimes it's for government, for the sake of government, but ideally in most cases it's for government, for community. And so I've got a multidisciplinary team across the full span of what I've talked about today. And it's about our internal structures, which allow me to get the advice from all of them. Translation of language, I think, has been a real journey for us, again, with that recognizing different skills and contributions here. On the social license front, we did a engagement piece, I think 2 years ago, and we're just about to rerun a survey. We used the Social Research Centre here in Australia. They've got what's called the Life in Australia panel. So a representative sample of Australians that they then draw on for social research. And so we did a survey on trust in data practices, and we're just going to revalidate that survey now. So I think it's about being clear, using those opportunities so that we're not stuck in the technical, and that we actually are getting the evidence base to kind of ground us in what people want as well.
Thank you. That's very helpful, Jacob. Patrick, do we have any questions for Jacob?
We don't have any outstanding, but we do have a couple of minutes in hand. So if anyone does have any questions for Jacob, do feel free to throw up your hand or drop your questions into the Q&A box. But otherwise, we can move on if there are no further questions.
Well, Jacob, thank you so much for your time, and thank you so much for taking us through that fascinating set of complex challenges you've brought to us this morning. So thank you for that. In that case, then, our final speaker on this session is Dr. Emanuele Massaro, who I believe is on recorded message.
He is, yes. So I will just set him up now.
Wonderful. Thank you, Patrick.
Good morning, everyone, and my name is Emanuele Massaro. I work at the European Environment Agency as an expert in environment, climate and health. Today I will present some analysis results, and I will describe the European Climate and Health Observatory, which is managed by the European Environment Agency. Let me start by introducing the European Environment Agency, or EEA. We are an independent European body operating at the interface between science and policy. With around 300 staff and a vast network of experts, we collect and translate environmental data into actionable knowledge for EU policy and decision making. It's a dynamic and impactful place to work, especially given the challenges Europe faces today. Our network is extensive. We collaborate with over 600 institutions and 3,000 experts to contribute to the IONET groups and 7 European topic centers. Together we deliver data, information and knowledge to support environmental policy across Europe. This collaborative structure is key to our effectiveness and reach. One of the main findings of our activity is that Europe is the fastest warming continent in the world. And this one is posing a lot of challenges, not only to our society and functionalities, to our infrastructures, but also to our health. It's important to understand how climate change is influencing the spread of infectious diseases in Europe and worldwide as well. So rising temperatures, changing precipitation, as well as extreme weather are shaping the risk of infectious diseases in our society. So basically, by the combination between climate and how this change could affect health became institutional. And that's why in 2021 the European Commission decided to establish the European Climate and Health Observatory under the Climate Adaptation Strategy. And the Commission has launched the European Climate and Health Observatory to better understand, anticipate and minimize the health threats caused by climate change. The European Climate and Health Observatory, as founded by the European Commission, supported by the European Commission and managed by the European Environment Agency, is composed by different partners. So we collaborate with different institutions, other European agencies and associations like the International Association of National Public Health Institute, IAMPI, to better understand and monitor the impact of climate on health. And there are also observers that basically they are not actively engaged in our report, our findings, but basically they are able to monitor and to basically provide suggestion and input to our activity. Just to give an example, I will show you a video that describes the European Climate and Health Observatory.
Climate change is one of the biggest challenges of our time, impacting not just our planet, but our health as well. Rising temperatures and extreme weather lead to serious health issues, from heat strokes and injuries to the spread of infectious diseases. Vulnerable populations are the most affected, highlighting the urgent need for action. That's where the European Climate and Health Observatory comes in. Our role is to monitor, analyze, and share vital information on how climate change affects health across Europe. Together with our partners, we develop knowledge about the most urgent climate health risks and identify solutions to addressing these risks. Our knowledge portal is a key resource, providing easy access to the latest data, reports, and tools to inform decision-making. We support policymakers, public health professionals, and communities to develop effective strategies that protect our health from the changing climate. Together, we can build a healthier, more resilient Europe. To learn more, explore our resources on the Observatory Knowledge Portal.
Okay, so
climate change is one of the biggest challenges of our
Stand by, folks. I think that might actually be the end. Hang on.
Climate change is
the observatory. I go with the objectives of the observatory. As I said, as also the video said, is to provide relevant information where users and different stakeholders can monitor key climate-related health risks, impacts, and adaptive responses through robust indicators. So this one is the collaboration with other partners and experts allow us to come up with important, robust information about climate and health. So in the observatory, you can find a lot of materials, a lot of information through analysis and literature reviews, through interactive pages such as maps, charts, and dashboards, as well as case studies. And we monitor the impact of the climate impacts on health by looking at different topics. For instance, number of heat wave days. We can have, we monitor the risk of infectious diseases in Europe, as well as fatalities associated with flooding. I would like to talk about a project that started recently and is in progress. But basically, this one is a project that wants to monitor the seasonality of infectious diseases, and we collaborate with the European Centre for Disease and Control to study the association between climate variability and infectious disease incidence in Europe, with focus on 3 vector-borne diseases: TB, Lyme diseases, and West Nile virus infections. This project is funded and managed by the European Environment Agency with the support and the supervision of the European Centre for Disease and Control. And the goal of the project is to strengthen the climate-informed infectious disease preparedness and resilience across Europe. And we want to study the spatial temporal variability of these vector-borne diseases over time. So we focused on 3 different, 3 specific diseases, as I say: TB, Lyme, and West Nile virus infection, on a period between 2010 and 2025. And we want to understand the relationships between climate and the incidence of vector-borne diseases. The idea is to monitor the spatial temporal variability, so how the how the distribution of the incidence has changed over the time, and also how the seasonality is changing due to climate change. And these are just illustrative example. Does not represent the real data, which is under progress. So we just started this project. But just to say that this is a result from the US Center for Disease and Control, is the visits for tick bites to the emergency department at the hospital, and we can see how this shifting is happening. So just to give you an example of how is important to understand how the risk of diseases is changing, to monitor their impact on society. And the idea is to, so what we are building the model to understand the association and the relationship between the incidence of vector-borne disease with the key climate variables, from temperature to precipitation, humidity, and so on. So that's the goal. I hope that, so basically we are working on it, and we will publish results by, let's say, beginning of next year. We do a lot of work on it as well. This one is a survey that we did with IAMFI to monitor the surveillance and preparedness in Europe related to heat-related mortality. We had this survey that showed that many countries in Europe have heat-related mortality procedure in place. Some of them not, some of them are working on it. But the most interesting things that came out from this report is how heat is defined. So for instance, this is an example of how extreme heat is defined across Europe. We can see heterogeneous indicators, so there is not a constant way to define extreme heat. We go from a temperature maximum of 26 degrees Celsius to a temperature maximum of 30 degrees Celsius. And this one is very important because different society and different people experience it in different ways. This is also the results that show that also the definition of heat waves is different across Europe. We go from a definition that is 3 days with a temperature maximum of 28 degrees in Norway, while the heat wave in Cyprus is defined as 3 days with a temperature maximum of 40 degrees, which means that a society and people are adapted to it in different ways. This one is a project which is EuroMOMO, is a European Mortality Monitoring Activities, that basically they receive data from member states about mortality. By doing this analysis together with extreme heat, is it possible to understand when excessive mortality is due to extreme heat? So that we are collaborating on this project to understand the impact and to come up with some indicators that can be applied across regions in Europe.
Patrick, are we at the end or are we stuck?
See, I suspect no. Hold on.
Another important report that we did a study is together with the Eurofund, is we try to understand how people are reacting to climate change, are adapting. So if they put in place something in their houses, if what is the let's say the difference in their socioeconomic behavior, to understand how heat is affecting our population. This one is in a survey on with to 27,000 Europeans, which is not representative of the population, but some of the results are basically are the same of the official statistics. So we can say that this report can give some important information. And one of the main results is the fact that the poorest people in Europe cannot afford measure to adapt to it, so they cannot install, for instance, air conditioning at home or insulate their place of residence, which basically is a very important topic, the fact that the socioeconomic exposure to climate change. We don't monitor only people without infrastructure. This is an example of how the extreme heat is impacting hospitals. For instance, in Europe, we can see that the 46% of hospitals in cities are in the center of the city, where the urban Italian effect is placed, basically. So basically in the warmest area of city, and that is also important because of mitigation and measure to reduce the impact of hospitals to extreme heat is a kind of a relevant topic nowadays. But the project that is quite recent is the calendar of heat waves of schools. So here we want to see if given climate, so schools, they have their own agenda, they have let's say year, which basically during summer, especially in southern regions in Europe, are closed, the schools, because of the heat. What happens over the year is the fact that extreme heat is not only happen in summer, but can shift to months before and earlier. So what is happening is that you can have heat wave in a period where people and children are going to school, which isn't somehow something that is very is a threat for our children, because most of the schools are not adapted to cope with the climate change. They don't have insulation, they don't have air conditioning, and that can be a threat for our children's health. Finally, I would like to say that our portal, you cannot find only data but also case studies. And this one is important because it allows us to understand how society is adapting to climate change. And we do that through different case studies and topics, from mental health, so how people, mental health of people, how extreme events are affecting mental health of population, to mitigation measure of healthcare facilities, and so forth and so on. So I would like to thank you with this. I would like to thank you a lot for your attention. I hope that you found this information relevant. If you want, you can contact me. My name is Emanuele Massaro. I work at the European Environment Agency. You can find me on the website and also on LinkedIn as well. So thank you very much for your attention, and I wish you a pleasant day.
Right. Well, that was excellent, Massimo. Thank you. Yeah, absolutely. Totoku, that clapping hands just coming up on the screen there. Well, that brings us to the end of this morning's session. Barry, I can see you with a hand up.
Yeah, I just think it would be interesting to reflect on we've had a number of presentations about climate change and health. And what it illustrates to me is how far behind the 8 ball, not even in the game, perhaps on the table, that New Zealand is. I don't know whether others have picked that up, but I think the Europeans and even Australia, certainly the Scottish people, and Scotland, I think, is a wonderful example where they've actually got the central agencies actually working with all these other agencies, but somebody's taken the lead. And you see even the Europeans. I don't see that in New Zealand, and it's a problem for New Zealand because we're going to be affected big time by climate change.
Well, we might argue that we are being so today, in a different way, but quite so. Does anybody want to reflect on what Barry's just said there? And indeed, from any attendees would want to say something on that, because I think it's very true.
They're all scared.
Yeah. Are there any other reflections people would like to make on any of this morning's sessions? Well, if not, I will hand over to Tim to close our morning together and indeed to close the conference with karakia. Tim, you're on mute.
Classic move. Morning, Naomi. Thank you, Richard, and a huge Naomi to all our speakers for the last 3 days, and also all the committee members who have been chairing, and of course, all you guys, our members, for asking really good questions and participating in PHONZ. We all really appreciate it. With that, I shall close with karakia. Mi karakia tātou, ke whakaria ti tapu, ke wātia atiara, kia turuku whakatau e, kia turuku whakatau e, humi e, hui e, tai ki e. Ka pai. Thanks all.